Okay, so this is my NG tube insertion video and removal. Hi, Miss Madison. I'm Nurse Lynn, and your doctor's ordered for you to have an NG tube. Can you tell me your full name and your date of birth?
Deborah Madison, 11549.
Okay, I'm going to look at your armband too, just to make sure that matches up with what you just told me. Very good. And that matches. And I've checked the computer MAR here. Yep. And it says we're supposed to do this in G tube, and it says the right patient and everything. So I've gathered my supplies, and I've washed my hands. And I'm going to put a little bit of this hand sanitizer on here too, just for extra measure. This is aseptic technique. This is not a sterile procedure. I'm going to hand the patient an emesis basin and a glass of water. She's going to need this in just a little bit. So the first thing that I'm going to do is I'm going to take my NG tube here. This is a Salem sump tube. And so I'm going to want to measure. We're going to start, oh, I'm sorry. The patient is in high Fowler's, and I'm going to have her look forward for me. So we're going to measure from the tip of the nose to the earlobe, okay? And then from there down to just below the xiphoid process. And then I'm going to, actually, some people use tape, whatever you want to use. I'm going to mark this so I can see it anyway. Maybe the best thing to do is actually put a piece of tape around there. Oh, no, that tore. Okay, so just putting that on there so we know where we're going. So I'm going to just leave this lay here for a second. I'm going to drape my patient so that we don't get anything on her when we're doing this. I'm going to don my non-sterile gloves. Then we will take this tube and put some saline, or not saline, sorry, some kind of lubricant here. We would have already kind of squirted that out. And I'm going to just get the tip of this moistened. And then I will take and coil this around my finger about, I don't know, 10-15 centimeters, just to kind of get this tube loosened up a little bit so that it goes in a little more smoothly. So we would begin inserting, and as we're going towards the earlobe laterally, and then when we get to the nasopharynx area, we're going to feel a little bit of resistance at that point. So at that point, we're going to tell the patient that she's going to start drinking water, and we're going to advance this tube 5 to 10 centimeters with every swallow. So we're gonna be twirling this. Actually, I need to back up. When I first put this in, I'm just going to rotate it slightly as I'm putting it in and going towards the nasopharynx. We will rotate it towards the opposite nair. And then when we get to the nasopharynx, as I said, she's gonna take a swallow, and we're gonna advance this down with each swallow 5 to 10 centimeters. And then so she's swallowing and swallowing. If the patient coughs or gags, we would stop, you know, make sure she's okay. And, you know, if it continues to be a problem, then we may have to discontinue the procedure, but it's not uncommon for them to cough a little bit. So, okay, I believe this is in now. So when you get to the point where this is to the nose, you can lift your head up now, Miss Madison. We want to secure this with our whatever device you have. Every hospital is different. So we'd want to go ahead and secure this down to the nose with whatever we have, whatever device you're using. And so then we're going to check placement by using our Toomey syringe, and we're going to withdraw some of the contents into the syringe and use pH paper to test it. So you would take this, oh no you wouldn't, I thought this had a cap on it. Nope, it doesn't. So anyway, so you just take the end of this off and you put your Toomey syringe in here. And we just withdraw a little bit of the contents and put it on your pH paper. And some contents are less than 5 for the pH, so then you would know you have placement. If you don't have the tube in the right area, then you would continue to advance the tube 2 to 2.5 centimeters, and then recheck placement. You want to check placement. I'm going to go ahead and take this off of you because I know that's not very comfy. Anyway, so you want to pin the excess tubing down to the patient's gown, and we're going to hook the end of this up to suction or whatever device you're going to use. You know, if you're not going to use it right now, then you'll want to plug this up. You don't want to use this if it's been on the ground, but I'm just, for demonstration purposes, just kind of plug that back up. And so if you have a patient that is comatose, you could get assistance from another coworker to help you. So also I wanted to say another way to check placement is to have the patient open their mouth and open your mouth, and then I would take a flashlight and I would look in there to make sure that the tube isn't coiled. You'd also want to do that if the person was excessively coughing or gagging, and then you would know that there's an issue, that it's not going in the right place. You want to make sure that you have a chest x-ray before you do any tube feedings, anything like that, and that is the official way to confirm placement for the NG tubes. You could use the aspirate check in between feedings and things like that, but you need to get that chest x-ray before you start doing anything else with it. So so I want to make sure that my patient is comfortable before I leave her. I'll take these things from you, Miss Madison, and you know, make sure her call light's within reach. I want to make sure she can speak. Can you speak?
Yes.
Yes, okay, very good. That's important, you know, make sure your patient can talk. That also further helps confirm that, you know, it's in the right place and there's no issues going on there. So anyway, so I would take all this down and I would, you know, dispose of all my items here and just make sure the patient's okay. So now for removal of the NG tube, which I should have left it attached to her nose, I'm going to come back in again on a later time whenever that date is that the patient is to have this removed. And so I'm going to once again come in and say, hello, Miss Madison, I'm Nurse Lynn, and we are going to remove your NG tube today. Are you okay with that?
Yes.
Okay. So I'm going to check her armband and make sure I have indeed the right patient. I'm going to double check the MAR to make sure that this was ordered, as we don't want to take it out if it's not been ordered. And we would not want to do this if she's been using that tube for feedings and she's had a feeding in the last 30 minutes. You'd want to come back at another time, you know, after a 30-minute time frame to do this procedure. So I'm going to come in and make sure my patient is in high Fowler's, and we're going to cover her up a little bit here. Just give her this emesis basin. You'd also want to give your patient some tissues maybe in between both. Sometimes they get a little teary-eyed even with insertion, so you give them some Kleenexes so they can dab their eyes or whatever. So the NG tube is already in here, you know, so it's in her belly there. And so we're going to come in and unhook any suction if this is hooked to suction. We're going to want to take this off and use our tuning syringe once again. Insert 15 cc's of, well, 15 cc's of water or air before we begin. And then as we're removing, it's a little difficult to do when it's not actually in place here. So we're just going to have the patient in the Fowler's position here, and we're just going to begin removing this tube very quickly. Just want to make sure we get it out quickly. Are you feeling okay, Miss Madison?
Yes.
We would have put a bag here too for our trash, and so we put this in the bag right away because you don't want drippings all over the place. So there would have been a bag here, and so then you would clean up your mess, make sure your patient is okay, that her call light is within reach, make sure she doesn't need anything, and hopefully that's everything.